You you made me sound great. Leave it in. Thanks so much to everybody for having me. I'm J.W. Randolph, as Jen said, in the Office of Strategic Initiatives with the Tennessee State Department of Health. Our office manages the County Health Assessment Program, which is going to take place in 89 rural counties beginning in 2019 and going through, well, in perpetuity on a 3-year cycle. Every county will do that by 2022. Prior to this work, I did community health needs assessments for a nonprofit hospital, the Vanderbilt Medical Center. We did those collaboratively with folks at St. Thomas and Ascension Health, as well as in Davidson, Rutherford, and Williamson counties. So 3 really different counties. I'm a disciple of the Church of Jen Drake Croft. So I love and admire her work and the work of TCCY and BSB and many of our colleagues across the state. So I'll go ahead and jump in to this process. So I'll do a brief introduction, give a background on the county health assessment process and sort of what it means for us as the Department of Health and what we hope it means for communities across our state. I'll talk about sort of what our results were from our first 16 counties who participated in the pilot county health assessment process in 2019. I'll share the 2020 counties that are just queuing up to go beginning here in January, and talk a little bit about the long-term vision for the county health assessment. So I love starting talks about adverse childhood experiences with pictures of my kids. I feel like it's a little bit of a presenter's privilege, but this work is personal to me. These are my daughters, Emma and Isla, and like everybody on the phone, I'm sure they're both above average, and they always get along, and we're always walking together as a family in the woods and not desperately begging each other to put on their socks 10 minutes before the school bell rings. This is us in a variety of settings. Jen mentioned I did my master's in public health at Vanderbilt University, and I was lucky enough to do my practicum and thesis work with Dr. Seth Scholler, who has developed an ACEs algorithm for patients who come into their primary care clinic. And so my thesis looked at a 1 to 2 minute intervention focused on high-risk families who could benefit from positive parenting practices. And so it was really a one small way that we can address parenting-related ACEs in the pediatric primary care setting. This was all after I was lucky enough to hear Jen speak at the Rutherford County Health Council probably around 2013. And so her work and others who worked on this have had a big impact on my academic and professional career, as well as the way that I raise my kids. So thanks, Jen, and other folks on the call. Before we go into the county health assessment specifically, I wanted to highlight something for folks who are involved in working on childhood development and who are interested in adverse childhood experiences and building resilience. This is just a short one-pager on the Tennessee Department of Health's strategic plan. This is a relatively new process for us, and something that my office has been given the task of managing, which we're very excited about. I wanted to highlight that all of the Department of Health's strategic goals fall under prevention or access. And for the first time, as far as I'm aware, preventing and mitigating adverse childhood experiences is a strategic goal of the Tennessee Department of Health. That is thanks to a lot of the folks who are on this call and your organizations. That's something that I personally am very excited about. There is a whole other project related specifically to how the Department of Health is going to do trainings on adverse childhood experiences awareness, as well as trauma-informed practices for our own staff and working with our health councils, et cetera, across the state. So I wanted to highlight that for this particular group. I won't go into it too much more on the call, but it's really exciting, and I think highlights that it's a priority for Dr. Piercy, our commissioner, who is a board-certified child abuse pediatrician herself, who understands that where you live, work, play is what's going to have the biggest impact on your health and well-being, and it's a priority for our department. So I wanted to start with something fun that I think illustrates why we do the county health assessments in the first place. So this is data from CDC Wonder. It shows 17 years of the leading 10 causes of death in the United States, as well as terrorism and homicide. They're at the very top. And so you see, we have about 60% of our deaths or more, depending on the year, that come from heart disease and cancer. Those are the big two things. Then we have accidents, lung disease, Alzheimer's disease and other dementias, stroke, diabetes, drug overdose, kidney disease, flu and pneumonia, and then suicide, homicide, and terrorism. You see it there at the very top. To go into the next slide, there are 4 pillars here. The pillar on the far left is the chart that you just saw, but just for 2016. So it's your leading causes of death: heart disease, cancer, road accidents, lung disease, et cetera, et cetera, et cetera. So there's what the data tells us is posing a threat to our mortality. The second column is what we Google. And so you see that tends to be pretty different than what is actually harming us. We do see a lot of attention to cancer, diabetes, and suicide, but those two things aren't necessarily lined up. The third and fourth columns are what we hear about. And so the third column is the New York Times, and the fourth column is the Guardian from overseas. So 2 different places, but what you see is almost identical. When it comes to what we hear about our health and what our decision makers hear about our health, what we hear a lot about terrorism and homicide and suicide, which is, of course, those things are not to downplay the importance of any of those things, but it doesn't necessarily match up with what we know and what the data shows us we could be doing to address the biggest threats to our health and well-being in our communities. So if you are in a public health program, if you are involved in community health needs assessments or anywhere in the public health spectrum, you've probably seen a slide a lot like this many, many times. And this is sort of what, this is a cornerstone of public health thought. And that's, it's really, really easy to focus just on clinical care. But we know that that's only a portion of what leads to positive health and well-being for individuals and communities. We know what's most important are the social and economic factors. So is there equitable access to education, to meaningful employment? Can people make a wage that's enough to live on? Is there social support, social groups within those communities that are going to be supportive of healthy lifestyles? Next, health behaviors, those things that we know, we shouldn't do: tobacco, unhealthy food and lack of exercise, alcohol and drugs, sexual activity. Those things also play a major role. And so we want to try and shift the conversation for communities to be focusing on those main buckets that really are the upstream drivers of what makes people and communities able to live a healthy life. Click one more time here. Let's see. Here we go. So I'm getting control back of the process here, and let's see if it will go through. All right, perfect. Thank you, Jen. So this is sort of how we feel when we look at the Department of Health and local health departments and regional offices. When we look at health councils and we look at different departments and divisions within our own department, when we look at the state health plan, we look at the governor's priorities. And I'm sure many of you feel the same way, particularly if you work in state government. And so, we see all these plans, and, it's hard to always know how to prioritize them and which ones to respond to. And so part of the job of our office within the department, and one of the goals of the county health assessments outside of the department in the state, is to align and simplify all the different plans that we all have to deal with. And so Another foundational public health principle is that the only way that we can really move those upstream drivers of health is through cross-sector collaboration. This is all about busting down silos and getting folks from different nonprofit groups, from different parts of government, from different parts of the private sector, who work in different sandboxes to kind of come together and to establish shared goals and to build a common action plan towards aiming at those upstream drivers of health that we know are supportive of individual and community well-being. So at the end of the day, the purpose of the county health assessment is to improve population health and prosperity across Tennessee by aligning our strategy department and our resources with local priorities, utilizing local knowledge, energy, and leadership. And so I think one of the real foundational principles of this is that we lead by listening. So we want to give communities a flexible process. And as they go through that process and establish priorities, we want to hear that as a department so that we can better respond to and support our county health councils and our health departments. If we see that every single health council wants to do a particular program or wants to work on youth nicotine, then that tells us that we may need to think about realigning some of our resource allocation or to think differently about our programming. And so this isn't a feedback mechanism for us to engage with the community across the state and to get that information back into our own planning. So I'll start by going over the vital signs, which are something that we provide to each county. The vital signs are 12 metrics meant to give a high-level overview of how healthy Tennessee is as a state. And so you'll see across the top, indicators that we're all very familiar with: obesity, physical activity, youth nicotine use, drug overdose. But we also, after hearing from folks across the state and going through a public engagement process on these vital signs, folks wanted to hear more about those things that we know are correlated with individual and community health, but aren't traditionally thought of alongside public health. So we also share information on the teen birth rate, community water fluoridation, which is a great local indicator of supportive policies around good oral health, frequent mental distress, third grade reading level, preventable hospitalizations, per capita personal income, and access to parks and greenways, as well as infant mortality, which I missed with apologies. But this is the framework that we sort of present to counties with local data. They'll have state and national comparisons as well. We also provide a resource called the Vital Sign Actions Guides. And so for each of those vital signs, our team has developed a database that includes programming, funding opportunities, education and awareness strategies for community, and policy recommendations for clinics, for communities, or for school-based interventions that are going to help those individuals and those institutions within the community to address the priorities they selected through the county health assessment. So feel free to type in, and Jen mentioned this, feel free to type in any questions as we go along. I'm trying to hit things at a high level and want to make sure that I don't get ahead of anybody. So the county health assessments are led by these county health councils, which I'll talk more about in a second. This year in 2019, we did 16 counties across Tennessee. And by 2022, all 89 rural counties in Tennessee will do a CHA. Tennessee has 95 counties. Shelby, Davidson, Madison, Sullivan, Hamilton, and Knox are what we call the metros. Those health departments report up to their local government. All the other 89 county health departments report up through TDH. So the goals of the CHA, as I mentioned, are to use data to drive collaborative action. Counties choose up to 3 priority issues. Those may be from that vital signs menu that I just shared. And they also are free to choose off menu. And I'll go into some of the results from this year because we were really pleased and surprised at some of the results and some of the things that counties chose. After choosing their priority issues, counties will develop an action plan utilizing those vital sign actions, or once again, choosing something off menu that they think their health council will be able to tackle in the creation and execution of a 3-year action plan. These were the 16 counties that were participants in the 2019 County Health Assessment Pilot. Chester, Gibson, and Henry out west, DeKalb, Fentress, Giles, Marshall, Stewart, and Trousdale in Middle Tennessee, and in the East Grand Division, Bradley, Hamblin, Hancock, Meigs, Monroe, Union, and Washington. And so those represented all 3 Grand Divisions. There were at least 2 counties from all 7 public health regions. And if you love maps like I do, I just love to look at this map and think about the real differences in a lot of these communities from West Tennessee, different economies, different demographics, different populations. And so it was really exciting to work with each of these counties and to watch 16 really distinct products sort of come from this process. So the health councils themselves, if they didn't exist, we'd have to invent them. As a public health professional, there's something that I'm so excited that Tennessee has and was so excited to learn that we have had. They were first established in the 1990s. They exist in all 95 Tennessee counties, and they're representative of multiple sectors within a community. And so that means that health department staff, coordinated school health, juvenile justice, BSB staff who are out in those areas, folks who work with kids, folks who are in law enforcement, folks who are with anti-drug coalitions, decision makers within the community, local elected officials. Those are the types of folks that tend to sit on these health councils. But I have to say also that certainly the Department of Health was negligent in providing them a direction for many years. Some did fine, but I think there's varying levels of engagement and bandwidth in each of those county health councils as of 2019. So part of this process, we hope, is building the county health councils back into a good, robust local community health coalition. We see them as the biggest underutilized resource for improving population health at the local level. And of course, we hope that the CHA process will get folks to come to the table to establish these shared priorities and to establish common goals that will get them moving in the same direction. So the CHA process is fairly simple. There are different processes that nonprofit health systems have used, that other state government agencies have used. We tried to just cherry pick what we thought would work from a lot of different community health needs assessment processes to make something that we thought was a good fit for Tennessee and that we thought would be a good fit for county health councils. And so the very first place that we start in this process is to ask our health councils to look around the table, who's there, who isn't there. If you're successful in wanting to implement a meaningful intervention in your community, who are the folks that are able to make that happen? And let's make sure we get them there at the beginning of the process rather than engaging with them at the end. If you do county health assessments, if you do community health needs assessments, I would implore anybody who's involved in that to engage leadership as high as they can, as early as they can. That makes it a lot more meaningful on the back end. We also want to have a focus on low-income, minority, and vulnerable populations. And so we provide tools to counties to say who in your community is not heard in these groups, who in your community is at risk for experiencing some of the worst disparities from when it comes to health and wellness in your community. After we go through that process, we'll look at secondary data using common terms. And so that means that we'll provide county level data for 3 or 4 years, as well as a state and national comparison. And what that lets counties do is really look and say, okay, we might perceive that you know, say terrorism as an example from the earlier slides, was a big threat to us. But, you know, it turns out that our immunization rate is not great, or that our childhood obesity rate is a lot higher than we want, and that's a place that's actionable for us. So we're looking at good recent local data. Third, we want to say, you know, data is not the whole story. Data is a character in a story. We want you to engage individuals and groups in your community who can share their expertise on what are the opportunities and barriers to achieving health and wellness in your community. So we give them an opportunity to engage, to do key informant interviews, to do community listening sessions, to distribute community surveys, so that they can add primary data to that secondary data that has been provided by the state. I think that's critical, again, with a focus on equity, encouraging folks to seek out the voices of low-income, minority, underserved, and vulnerable populations within their county. Fourth is counties will establish shared priorities. We've asked counties to choose no more than 3. It's easy to want to try and do everything. You can't boil the ocean, yada, yada. So the more specific we can get, the easier it is to fill out that action plan and for the county to organize around taking meaningful steps. And that's really the purpose of all of this, is to develop a collaborative action plan and to implement and execute the steps in that action plan. It's no good doing assessment if you're not going to utilize that data. And this is data for action. And so we want this to be a mandate for communities to take big steps to address common issues within their community. So I'll walk through the timeline really quickly. It's a 6-month process. And so we begin by doing an overview of the CHA, by doing secondary data analysis, primary data collection, identifying priorities, and then we've added a lot towards the end of the process this year to allow for more action planning. That way, the health department has time to respond as they're doing their strategic planning. That way, folks aren't breaking for the summer and taking a 3-month hiatus before they come back and try and say, what were we talking about again? And so by month 4, we were having to identify these priorities and then to take a while to really drill into that action planning. So counties have taken that a lot of different ways. Some groups are breaking up into the subcommittees. So if they chose obesity, there will be an obesity subcommittee, and those groups are meeting more often and may contain subject matter experts. And they'll bring that work back to the whole health council. Some groups just chose to say, hey, we're going to keep meeting as a full council, and we're going to knock out this priority first together. So we've tried to build in that flexibility to meet the health councils where they are. This is an example of the data package that we provide. There are a lot of gray boxes here, and that's both unfortunate and for a reason. We wanted to be able to say, you know, these were the indicators that were really important to our county health department directors. These are the vital signs, as well as a number of other local data that folks say they really want to see. And we hope that this encourages our department and others as well to do a better job of surveillance in collecting and sharing these data. So I was also really impressed at how enthusiastic health councils were about doing primary data collection. We had 12 councils that did key informant interviews, 12 councils that did community surveys, and all 16 counties did at least one community listening session. And even if that was something as simple as holding a listening session among members of their health council, it gave them a chance to dig deeper into some of the questions that they had. And a lot of counties went well above and beyond that as well. So with that said, I'll start walking through what some of the results were this year. As I mentioned, we had 16 counties, and far and away the leading choice, which may not come as a surprise to anyone, was substance misuse. Bradley, Chester, DeKalb, Fentress, Gibson, Hamlin, Hancock, Henry, Marshall, Meigs, Monroe, Trousdale, Union, and Washington all selected substance misuse This has helped us organize with our partners at the Tennessee Department of Mental Health and Substance Abuse. This has helped us organize with the Opioid Response Office within the Department of Health to really reach out to these communities because, you know, they're all highlighted on this map, but you have 14 counties that are dealing with this in really different ways in reality. The next most common selection was mental health. So Chester, DeKalb, Fentress, Gibson, Giles, Henry, Marshall, Trousdale, and Washington. This came up as mental health. Sometimes this came up as things like suicide, frequent mental distress, but basically we have a lot of counties highlighting that folks are under a lot of stress, that there's a lot of depression, that there's a lot of anxiety, and a need for prevention and a need for access to treatment related to mental health. Next was obesity, which was also chosen by 9 counties: Bradley, Gibson, Giles, Hamblin, Henry, Marshall, Meigs, Stewart, and Trousdale. The health councils are a great group to work on obesity because they tend to draw in stakeholders who are involved with children and with young families. They tend to have a representative from coordinated school health, folks who are involved in local nutrition and physical activity activities as well. So this again wasn't too big of a surprise. We had youth nicotine use as well: Fentress, Giles, Hamblin, Monroe, and Stewart. I was a little surprised at the lower number of folks who were interested in working on nicotine, and I think it'd be interesting to see if a lot of the news about vaping illnesses and deaths had happened earlier in the year, if that would have impacted this. I think there's also a lot of burnout from working on tobacco, frankly, at the local level over the last couple of years, and so a lot of counties are already working and doing a lot of work in this space. And so I think it's important to note that the last few priorities that were selected by a lot of counties were from that vital signs menu. So this was kind of within the framework of you know, what we provided to them and sort of what we expected to hear. But the next most commonly chosen priority for counties was adverse childhood experiences, where we had DeKalb, Union, Hancock, and Washington County come sort of on their own terms and say, this is a really important issue for us and one that we really want to work on. That was encouraging to us because it let us know that the CHA process was facilitating these conversations about what are the upstream drivers of health, how can we get people to collaborate to really do the good prevention and mitigation work around those factors that have a long-term impact on our health. And so many came to ACEs. We also have a lot of other priorities that counties came to, including 3rd grade reading level, teen pregnancy, lack of child care. In Chester County, there was also a lot of robust discussion about ACEs in that conversation. Minority health in Marshall County, access to affordable health care, health literacy, community violence, and a lot of that, again, there's discussion about ACEs there in Washington County, where there's a real interest in addressing interpersonal and relational violence, and cardiovascular health in Monroe County. So I wanted to again highlight DeKalb, Hancock, Union, and Washington as the 4 who explicitly said we want to work on adverse childhood experiences. And so this is an example of the action plan, and I've de-identified these because they're just starting to come in, and counties are kind of working out what they want to do. But I think the real surprise and something that I was really pleased by is, you know, if a county wants to work on ACEs, it's almost like saying, you know, that we want to work on disease. And so what counties have tended to do is to say, we want to work on ACEs, and we're going to also work on 3rd grade reading level to really be able to address both. Other counties have said, we want to address ACEs and substance misuse. Our action plan for those priorities is actually going to be one and the same. We think that by building supportive institutions and programs in our community, by focusing on vulnerable children and families, we're not only able to prevent and mitigate the impacts of ACEs, but also address the root causes of mental illness and substance misuse. And so that was so exciting for us, and I think is a really intuitive way that counties are going about addressing the impacts of ACEs. Here's another example of addressing their substance abuse and ACEs in the same action plan. And so these are super simple. County health councils, as I mentioned, are volunteer institutions, but we ask them, their strategy. We put in who's responsible for it to help create some accountability. We ask them to list outcome measures and then look at progress towards their outcome measures. And so that's what will be on all the action plans, and we're really excited to see these be developed within the communities. I wanted to highlight a few of the ACEs and trauma-related resources that we rely on. A lot of folks who are on this call, I know BSB and TCCY, Prevent Child Abuse Tennessee, Voices for Children, Coordinated School Health, and lots of other childhood and trauma-informed practice advocates. I've hyperlinked to these 3 resources that we utilize on the slide. I hope you're familiar with them. If not, they're 3 really great resources. The first is Preventing Adverse Childhood Experiences, leveraging the best available evidence that's recently released by the CDC. The second is from the National Advisory Committee on Rural Health and Human Services from HRSA, to look at the rural context for adverse childhood experiences and how that's unique from what non-rural populations may have experienced. And then from ETSU and Ballad, Becky Haas and other folks have put together the Building a Trauma-Informed System of Care toolkit, which is really fabulous, and I would encourage everyone to give that a look. And so I would be, I'm all ears for other folks if you have additional resources that you think our communities could utilize. If there are good, action planning guides or, toolkits for communities to use to prevent and mitigate the impacts of ACEs, please share those with us, and we would be all ears because we want to make sure that folks have the best that we can bring them. So we recently did an evaluation of the County Health Assessment Program, and I just wanted to share a few comments. It was mostly positive, and there was some feedback which we take to heart and try and change for the upcoming year. But wanted to share a few comments. Folks said this process rejuvenated our health council. It was nice to see some of our more seasoned members get excited about our group again. It caused us to stop and think about the big picture, about the health issues and the needs of our community. We're all so busy working in our area of expertise. I think that this global look at our community was important. Collaborations with other facets of health professionals. The interaction and participation of all health council members. Everyone from the community set the goals and not just in their own area. And having time for little voices to be heard. That one was really pleasing to all of us because, as I mentioned, we want to be deliberate throughout the process in making sure that a diverse group of voices are not only around the table and are not only able to share their perspectives, but also that perspective is heard and continually sought out. So those were some of the positive things that we heard from county health councils. These are the 2020 county health councils. We're going from 16 to 27 in the upcoming year. And so we're really excited about that. It will be, once again, I think really fascinating to see the life that these different processes take on in various counties. I've shared on the slides, and I'll send this to Jen, and if she can share those, it will have the CHA counties for 2020, 21, and 22, so that if you or a partner of yours or field staff of yours works across the state, you'll know sort of when the county health assessment process will be coming up in that county. We want to make sure that as many folks as can be are involved in their health councils in preparation for the CHA, and then really for the action planning and execution of that action plan. Finally, I wanted to mention that we're building and are about ready to release an updated website that really is meant for members of the community. It's meant for non-public health folks who may sit on those health councils. And so for all the vital signs, we're building out additional information based on 3 questions. I picked access to Parks and Greenway here, but we really want to explain, what do we mean when we talk about this indicator? Why is it important to health? What are the disparities and inequities? We've created explainer videos that are very short and fun related to each of the vital signs. And then communities will be able to access the vital sign action guides here in the tables below. We're really excited to be able to put those out onto the web for anyone to access and give us feedback on as well. So I'll wrap up quickly and would love to answer any questions or hear other folks' thoughts. Ways you can be involved are, if you have field staff or collaborators, please make sure they're connected to their health council. If you live or work in one of these 89 rural counties, please make sure you're involved. They're great groups, and it's a great opportunity for us to do this cross-sector collaboration that I think we all know is best and want. It's a great chance to put it into action. If you work particularly in a metro, those counties tend to be well ahead of where a lot of the rural communities are. So places like Davidson County work with Vanderbilt and Ascension and St. Thomas and do collaborative CHNAs, the community health needs assessments. A lot of these metros are already doing work with their local nonprofit hospitals. And so we've actually had a lot of really good lessons learned from the work that the metros have been doing. And I would encourage you to seek out the health council in those metro areas and to get involved there as well. There are lots of opportunities to connect with the county health councils with your work. If you work on ACEs or trauma-informed practices, I think you'd be a great fit for providing resources and information to your health council. Whether that's funding opportunities, programming, or resources that exist that other folks may not know about. And lastly, keep up the good work. I know a lot of folks who would be on this call are doing work that aligns really well with the county health assessment process. So thank you and keep it up. The long-term vision for us is that we want the county health assessments and vital sign actions to inform the department's strategic planning process and to really learn from community experts from across the state. We want to be able to build a robust, user-friendly website that houses a lot of this information and resources that are easily accessed by county and by topic. We hope that will be able to help county health councils who historically have been fairly isolated. We hope this will help get them in touch with each other and to learn more about what the health council, the county over, may be working on and how you can collaborate there as well. We're going to continue to grow an ecosystem of resources for each vital sign to serve as roadmaps for the counties and continue to build resources that really make that decision architecture as simple as possible for folks, and to empower county health councils to establish a sustainable process where counties can engage in conversation and cross-sector collaborations that address upstream public health challenges. And with that, I want to thank you for listening to me talk for so long. It's not my preference either, but I hope that it was informative, and I'd be more than happy to hear thoughts or to answer any questions.
Awesome. JW, that was fabulous. And I just want to, while we're maybe waiting for some questions to come in, I just want to let the folks know that those of you who are part of or are familiar with All Children Excel Nashville and Davidson County, this was how ACE Nashville got its start. So we, through the CHA process, adverse childhood experiences, or actually mental and emotional health, rose to the top in terms of priorities, and then adverse childhood experiences were a strategy to address that top priority. And so out of that and their community health improvement plan, otherwise known as the CHIP, ACE Nashville was really born, and in the past 4 years, amazing things have been able to come out of people just coming together and addressing this issue. And so it's just inspiring to me to see other communities use this vehicle to begin to move upstream and prevent a lot of the mental health and physical health and social issues that we struggle with as a state. So, JW, I'm not seeing any questions coming through so far. We'll give folks a few moments and see if they have anything to say. So, there's one maybe Q&A that popped up. Oh, you got a compliment. It says, really excellent overview. Thank you.
My pleasure. Thanks. Thank you. That was the easiest question I'll get all day.
That's right. That's right.
Thank you, whoever that was.
All right. Well, like we said at the start of the webinar, this is going to be recorded, and though we make these webinars live to our Building Strong Brains trainers, we publish the recorded webinar publicly on our TCCY YouTube page, and I'll also be emailing the webinar out and posting it to Basecamp. So, JW, thank you so much again for your time today and for helping people understand how they can really affect change in their community.
It was my pleasure. Thank you, Jen, and thanks to everyone for listening. If you have any questions or thoughts, my email and phone will be on the slides, and I'll look forward to connecting with everybody soon.
All right. Have a great day. Bye, everybody.